everybody. Today I'm going to go over joints. There's a lot to this, so let's get going. All right, so joints are where two bones meet. It's where the body movement occurs. And so you have joints, there's joints within the wrists themselves. There's also, your elbow joint, all right, that we have here that you can see between your humerus, and your ulna, which is a hinge joint. There's a trade-off that exists between the strength and the mobility of a joint. All right, so this is really strong, but this can only go in two planes. All right, whereas our shoulder is a ball and socket, it's not as secure, but it can rotate in several planes. First, we want to talk about the structural, the anatomy, and the functional part of a joint. Okay, so I was talking about the structure of the joint, its anatomy, and then we want to look at the range of motion. The joint structure determines the function. There are fibrous joints, cartilaginous joints, bony joints, and synovial joints. And we're going to spend most of our time on synovial joints. The classifications on how they can function have different names. There are synarthrosis, which are immovable joints. There are amphiarthrosis, which is slightly movable joint, and diarthrosis, which is a freely movable joint. You can think of a synarthrosis as like a suture. All right, the sutures that we talk about in your skull, those aren't really moving. And then we're going to go through these: slightly movable and then freely movable. So synarthrosis, like I said, think about where, your frontal bone and your parietal bones come together. You can think of, how the edges of the bones come together in a suture. It could be fibrous, it could be cartilaginous. You have sutures, gomphosis, you have those in the gums, synchondrosis, and synstosis. So your sutures are synarthrosis. Your gomphosis is how your teeth bind to bony sockets. So there is actually a fibrous connection. So you might have heard of people going to the periodontist. That's a more specific area in dentistry. There's a periodontal ligament there. Synchondrosis, there's a rigid cartilaginous bridge between two bones, and you're going to find this between the vertebral sternal ribs. So take a second, remember what that is: vertebral sternal ribs. Okay, so think about that from the vertebrae, those ribs that go from the vertebrae to the sternum. The epiphyseal cartilage of the growing long bones. Synostosis is when the two bones fuse together. So this could be a suture of the frontal bone. So remember, like how the frontal bone forms, we talked about that with babies, in the epiphyseal line of a mature long bone. So remember, we looked at the growth plate and the line that is left over, all right, when the growth plate fills in. Amphiarthrosis are more movable. They're stronger than diarthrosis. The two are, one that you're familiar with would be the pubic symphysis. So remember, we had that. I don't know if we can see the skeleton, but remember, you just had that on your last test. Or a syndesmosis, that would be bones connected by a ligament. Synovial joints, the diarthrosis, these are what we're going to spend the most of the time this chapter. These are freely movable. These are at the end of long bones. There's going to be a joint capsule that contains a synovial membrane. The synovial fluid from the synovial membrane will fill the joint cavity. And remember, there is articular cartilage. So when we did the long bone dissection, remember at the end was that smooth white cartilage. That is covered it. That's your articular cartilage. So we're going to take a look into the capsule of a joint. So here is a diagram you need to be familiar with. So remember the long bone and the long diaphysis, there would be the periosteum, and here's your spongy bone. And remember, here's the medullary cavity. And remember, in there would be the bone marrow. So just a little review there. Here's the long part. Here's the compact bone. This is the metaphysis. That's where the epiphysis and the diaphysis come together. All right, so that's review. We are on joints, so we want to, look at the new information. So you can see these two bones, and this is just your basic model of a synovial joint. This is a sagittal section. All right, so you can see here that on the outside, right here, this blue, this is a ligament. This makes me think of like a knee, but this is just a general diagram, okay, because there's ligaments on the outside of your knee. There's a lateral on the outside, medial on the medial side, collateral ligaments. And then you should see that there is this synovial membrane right here. You can see that, and there's going to be synovial fluid in there, but it doesn't show you. But here's the ends of the bones. It has that articular cartilage, and this whole thing is enclosed by the joint capsule, which is more of that white part that you see there. So the joint capsule has the synovial membrane. All right, and you can see at the end of the bones, there's the articular cartilage. And then this is the cavity, the space that will have the synovial fluid, and that's going to allow there to be less friction. Now, I told you about my son's knees. His one knee, he didn't really have any more of this articular cartilage. So that was his first surgery, and that was basically, it's something from when he was born. It's very strange. So it just worn away because of his bones not forming correctly, especially on his left leg. So you can imagine that could hurt to be like bone on bone. All right, here's another picture. I'm not going to go over everything, but like your joints. So if we look here, here's the articular cartilage of the tibia. Here's the articular cartilage of the femur. This is some fat, which is good for around the body. Not too much fat, but it's good. Here's the cavity in black. And then you can see that there is, like in the knee, you have meniscus, which is another form of cartilage that helps cushion. Fortunately, that is fine for my son. All right, and then you can see that there are tendons that attach muscle to bone. All right, this is going to be the patella here. And then, let's see, this is just going to be the joint, the synovial membrane here in this light pink. And I think that's it. Oh, the bursa. The bursa is what I want to show you. So this, this is a sagittal section. So it looks like a mid-sagittal section. So remember, right and left. So if you took your knee, it was like this. So you have a bursa on your knee, and it helps protect the knee from excess shock. It looks like there's one back here. It looks like there's some other ones here as well. But you can, sometimes people get a goose egg on their knee, and it's just like the bursa swelling up. Synovial fluid, I talked about that. Lubricates and helps absorb shock. And it has the consistency of like an egg yolk, which is kind of weird. And it has these protein carbohydrate complexes in them known as proteoglycans. And it's really important for movement in a synovial joint. So I pointed out some of those structures before that help stabilize the synovial joints because they're pretty weak, actually. There's a trade-off. They can move more, but they're not super strong. So that's why you're going to see cartilage, fat, ligaments, tendons, and the bursae. Meniscus are it's fibrocartilage, and they're pads between two opposing bones. The fat pads I showed you was all yellow in that membrane. That protects the articular cartilage. And this is adipose tissue, just to bring in a little tissue there for you. Ligaments, they support and strengthen the joint. Okay, ligaments are bone to bone, and often you can get a sprain. Biggest area is a sprained ankle, and that's when you tear the collagen fibers of the ligament. Tendons attach the muscles to the bone. You can get tendinitis, which is inflammation of a tendon because you keep irritating the tendon. Bursa, those are the small pockets of the synovial fluid, and they cushion the area where there's the tendons or the ligaments that are rubbing against other tissues. The synovial joints also have factors that help stabilize them. And so basically, you know, humans, we walk erect and we need to move. So again, there is a trade-off. So there's structures that the human body has for protection. Basically, our joints prevent injury by limiting range of motion. So there's collagen at the joint capsule, there's ligaments. How the shape of all the surfaces are and the meniscus and other bones surrounding help with this. Okay, moving on. There are movements, and you guys are going to do an activity where you learn these movements, but this is a good introduction to the movement. So don't worry that if you don't understand it right now, because you will actually be doing these. So movements are described in the plane or the direction of movement, and also the relationship between structures. Planes of movement, there's monoaxial, biaxial, and triaxial. So monoaxial is one plane, so your elbow, one plane. Your wrist, okay, can go abduction, abduction, flexion, extension. Shoulder, 3 planes, okay, so it can rotate, it can circumduct, it can flexion, it can extend. So when you have those ball and socket joints, you'll see that it can be triaxial. So in synovial joints, there's gliding movement, angular movement, circumduction, rotational movement, and special movements. Gliding is when 2 flat surfaces slide past one another, all right? And so this would be between your carpal bones, so that they do slide past one another when different motions take place. If it's an angular movement, these are flexion and extension in the anterior posterior plank. So if you flex, all right, so if I'm using my elbow joint, so I'm decreasing the angle. So you guys know this is 90 degrees. I'm decreasing the angle as I flex. If I extend, I'm extending or increasing the angle between the 2 bones. If I hyperextend, that's extension past normal. You know, if this is extension and I went down further, I hyperextended past the normal anatomical position. All right, and we're going to be doing these labs. So here's some flexion and extension, and you can see the hyperextension here in the wrist. Abduction is moving away from the body. Adduction is moving towards the longitudinal axis. So I could even do abduction, adduction this way in my wrist. All right, so I was trying to show you. I'm sitting, okay. So abduction, adduction, you can do it with your legs as well. We'll be doing all of these. And here you can see with your fingers, abduction, 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 abduction. Circumduction, complete circular movement without rotation. So you can see with the arm here. I'm going through these kind of fast because you will be doing an activity with these. Rotational movement, there can be just left or right rotation of the head. All right, medial rotation. So we can talk about medially rotating the shoulder or lateral rotating our shoulder. So internal rotation is the same as medial rotation. External rotation is lateral rotation. So like I showed you like this, and then I showed you the lateral and the medial rotation. Pronation and supination. So you might have heard like COVID patients early on, they're putting them on all of these ventilators, and then they realize if they make the patients lie prone, okay, it's more successful. So, you know, if they're prone, they're like laying on their stomach. All right, if we talk about pronation with the arms, the palm faces posterior. So like anatomical position is like this. If we want to pronate, remember the radius rolls across the ulna, okay, and we're now in pronation. If we supinate, that's anatomical position. And I always think of holding a can of soup or a bowl of soup, okay, you're going to supinate. Your forearm is supinated in the anatomical position. Also, they might say, put the patient supine, that's laying on their back. So like this. So there's your pronation and your supination. All right, special movements, inversion. So this is with your foot, so I'll show you the pictures, but you're gonna, like if you have your feet right now on the floor, try to put the medial part inward, so like this. Okay, eversion, then try to go out on the outside of your foot, and then dorsiflexion. Right now, I want you to bring your toes towards you, and then plantar flexion, you can go up on your toes like a ballerina. So here's the inversion and the eversion, dorsiflexion and plantar flexion. All right, lots of movements, everybody. And I know I'm going fast. There's special movements. So opposition, very cool thing humans can do. We have an opposing thumb that makes us a human. All right, so that's a big deal. And that's opposition. You know, just even going like this. A lot of other living things don't have the opposable thumb. Reposition, okay, so that's, you know, opposition of opposition. So like here's opposition, okay, reposition, going back. Protraction and retraction, anterior movement of the horizontal frame and retraction. I will show some pictures of these. So there's opposition. Here's the retraction and protraction. So you can see that if you bring forward and then backwards, pro is forward, retraction is bringing it back of your jaw. Depression, okay, bringing it inferiorly so we can think of our shoulders. Elevation, all right, moving superiorly or up. Lateral flexion of our vertebrae, side to side. Oh, I should have thought of the jaw on this one. Also, you know you can just depress your jaw. And as I'm going through these, you can try some of these. Lateral flexion of the neck, and also do it of the spine. All right, so when we do these activities in class, you'll want to think about the different type of synovial joint. So there are a bunch of them. And so a plane joint is a flattened, it's a gliding joint. There's not a lot of motion. Hinge joint is in a single plane. Condylar joint, okay, you might think of condyles that we've learned before. This is the oval or articular face with the depression. It's a motion in two planes. These are biaxial. So Your book does a pretty good job with these. Your hinge joint, you can see your elbow joint. The knee joint is a modified hinge because there's not like the bones like completely connecting like we see here in the elbow. Your ankle joint and your interphalangeal joints. Okay, so you can, you have little, you can, grab something with your hands. Condylar joints. So you can see that there is like an oval articular surface that is nestled with the depression on the opposite. So the radial carpal joint. Okay, so where your radius comes together with the carpal. So you can see right here, it's your scaphoid right there. Your metacarpal phalangeal joint and your metatarsal phalangeal joints. So this is biaxial. Okay, so two axes. Other movements are your saddle joint, which is your thumb. It's biaxial. A pivot joint, which is only rotation, and a ball and socket joint, which is triaxial. And there's a round head, like in your shoulder, and in the hip. All right, so we're going to look at these. So the saddle joint, it's your first carpal metacarpal joint. So right here, you have your trapezium at the thumb. All right, and then here is your metacarpal bone of the thumb. Okay. That is biaxial. Your pivot joint. All right, so this is a lantoaxial joint. So remember your axis. All right, so you can say no. Okay, so this is the proximal, and then also the one, another one is a proximal radial ulnar joint. This is monoaxial. Ball and socket is going to be triaxial, and this is going to be like your shoulder joint and your hip joint. And you can see back and forth, you can see completely going around, and there's a ball that's in the depression of the socket of another bone. Vertebral movements. Your vertebrae can move, flexion, extension, lateral flexion, I was showing you that before, and rotation. So think you turn. So think of all the, how stable your vertebrae is. All right, so we're going to look at all of these joints, and this is where we'll spend more time. Today is more of an introduction. Hinge joint. These articulations in joint, involve the humerus, the radius, and the ulna. So here, I just want to point out some ligaments. There is the annular ligament right here. And that you would see, I know I only have the radius right here, but it goes right around the radial head. Okay, so you can see from this right here. And then this is going to be the radial collateral ligament. This is your capitulum on the humerus. I should show you, this is your lateral. Okay, so remember anatomical position. So this is when it's radial collateral. Okay, that's your radial side, that's your thumb side. Okay, so you could say lateral collateral ligament, but radial collateral ligament means the same thing, and it helps you understand that it's by the radius. This is a medial view. So there's that annular ligament there. And then now we have an ulnar collateral ligament that you can see. And this is we could say this is the medial, but that should make sense. That's the medial collateral ligament. We have that in the knee too, but we call it the ulnar collateral ligament. So that should be helpful when you're trying to remember where these ligaments are. Your knee joint is a modified hinge. It's very complex. There's 2 femur tibia articulations at the medial lateral condyles and 1 between the patella and the patellar surface. There are a lot of supporting ligaments. There's more to this, but we are going to talk about the 7 major ones. Patellar, there's on the anterior side, the patellar ligament. On the posterior side, popliteal ligaments. There are 2 anterior cruciates, 2 cruciate ligaments, 1 anterior, 1 posterior, that are inside the joint capsule that are very important to the stability of the knee. The tibial collateral ligament and the fibular collateral ligament. So same thing like when I was talking about the radial and the ulnar collateral, these also can be called the medial and the lateral collateral ligaments. So here you can see, here's your patella. And I just want to point out there's a quadriceps tendon here. Tendons attach muscle to bone. So your quadriceps are very important muscles. If you have a knee surgery, you need strong quads because it helps support your knee. So here's your patella. Here's the patellar ligament. Sometimes people have patellar tendonitis. It's going to be in that area, but here's your patellar ligament. And then here, this is going to be your tibial collateral ligament. So that'd be the medial one. And then here is going to be your fibular collateral ligament. Looking deep, so we pulled that patellar ligament off so we could see. Here's the patellar surface. Here's your condyles of the knee. And then now you can see in the back, look at this for me. The back is the posterior cruciate and the anterior is on top of that posterior. So sometimes kids have a hard time looking anteriorly and know which one's the anterior, but like it is anterior. Okay, it's in front of the posterior one. And they do cross. This is the big one that a lot of people in sports, contact sports, running, they can tear. And girl soccer players can tear this more easily because they have a wider Q angle. Their hips are wider, so the angle of the knee puts more stress on the knee. And then I want to point out these meniscus right here. The meniscus are these cartilage pads that cushion between the condyles of the femur and the tibia. And then you can see, here's your fibular collateral ligament. And over here is going to be the tibial collateral ligament. The unhappy triad is when people, they tear their ACL, they tear the MCL, and the medial meniscus. That's often what happens. A lot of times they get hit. They get hit laterally, and it tears everything medially, basically, with your anterior cruciate as well. Okay, so here's your femur. Here's your tibia. We want to look here at the ligaments that stabilize the knee joint. And so this is on the back of the knee, the posterior view, and here's the popliteal ligaments. All right, so we're not deep. All right, and there is a popliteus muscle right here. Okay, but this is a popliteal ligament. And then you can see your tibial collateral and your fibular collateral ligament. And so this one I like to show, this is the anterior, but now we're the posterior view. So here you can see your posterior cruciate, you can see your medial meniscus, and you can see the lateral meniscus. All right, your shoulder and hip joints. The shoulder joint, ball and socket, diarthrosis. It's the head of your humerus. Okay, and then you learned last chapter, it goes into the glenoid cavity of the scapula. Greatest range of motion of any joint is the shoulder joint. It's also the most frequently dislocated, all right? So it has great motion, but it's not as supported as even our other ball and socket, which is the hip joint. So the joint capsule, because it's very shallow, there's a glenoid labrum. And so this is fibrocartilage that will extend beyond the bony rib. And this deepens the socket of that glenoid cavity. So if you remember when we looked at the glenoid cavity, it wasn't that concave. It wasn't like this, where the humerus could fit in. It's more kind of like shallow like this. So the labrum helps deepen the socket. The acromion and the coracoid process help stabilize the joint. And there's all these muscles and bursa that help support your shoulder joint. All right, these are your rotator cuff muscles, and I will teach you these next semester, the 6 muscles, supraspinatus, infraspinatus, teres minor, and subscapularis. And then there are all these bursa sacs that help protect the shoulder joint. So just taking a look here, here's the joint. You can see here's the joint cavity. This is basically here's some articular cartilage. This is the labrum right here. So this is, you can see how the head of the humerus is fitting into the joint capsule. And you can see all the different ligaments and muscles. Here's your acromion, and that you had to learn. We didn't make you learn the coracoid process, but that's on the scapula too. And you can see there's the coracoacromial ligament. All right, so it helps stabilize the joint. So here's what I wanted to show you from this view here. This is the glenoid labrum right here, and this is the cavity. So that's going to help deepen the socket. And then with all of the different tendons and muscles that you see around it and ligaments, that helps stabilize the joint, but it still has the most movement, but less stability. Hip joint is a stronger ball and socket diarthrotic joint. Wide range of motion. It has a labrum as well that's called the acetabular labrum. So on the skeleton here, remember this is your acetabulum. And this labrum increases the depth of the joint cavity. It also seals in the synovial fluid. There are many ligaments that fill in the hip joint. Fill in. I don't know why I said fill in. Ligaments of the hip joint, and you should be able to figure these out. Iliofemoral, so it's going to go from the ilium to the femur. Pubofemoral, pubic bone, femur. Ischiofemoral, okay, the ischium to the femur. Then there's a transverse acetabular, I would think going across the acetabulum somehow, ligament of the femoral head. So with the femur, okay, you just always have to think about what these words mean. So this is a lateral view. This is your acetabulum right here. This is going to be right here, the acetabular, this labrum here. This is going to be the cavity and full of articular cartilage. And let's look at some of these ligaments. So just to point out a couple things, here we are on the femur. This is your greater trochanter. This is your lesser trochanter. So if we follow this is the iliofemoral. So if you follow it, it is going from the ilium to the femur. And then here, it's going to kind of go under, but this is the pubofemoral. So it looks like it's going to go tucked down under here. And then here again is the iliofemoral. And then here is the ischiofemoral. And that was, I should have pointed this out. This is a posterior view. You should have seen there. There's your ischial tuberosity, and here's your greater and your lesser trochanter you learned last chapter. All right, one thing you will be doing is a project in this class, and you will do an injury, or a condition. So there are a couple I want to mention. Some people have different forms of arthritis, and one is rheumatism or rheumatoid arthritis, and this causes pain and stiffness in the musculoskeletal system. Young people and old people can have this. Arthritis, remember, itis at the end of the word means inflammation of, and so this is inflammation of the joint. This occurs in all rheumatic diseases that affect our synovial joints, which is what we've been talking about. And then generally, most people over the age of 60 have osteoarthritis. This is from wear and tear over time on your joints. The more active you are, maybe with your job, certain areas you might be more affected by as you get older. There's also genetic factors that affect collagen formation. Degenerative changes, so that rheumatoid arthritis, it's inflammatory. Your immune system actually attacks the joint tissues. So this is more of an autoimmune disorder. Gouty arthritis, people get this when they tend to have diets that are rich in fatty foods, or a lot of sugary foods too. So basically, uric acid crystals form within the synovial fluid, and people get this in their elbows. It might look like a huge bursa sac if it's inflamed, or in their hallux, their great toe. Degenerative changes, what happens is people become less or more sedentary, I should say. They don't move around a lot, so there's not as much flow of the synovial fluid, and this causes symptoms of arthritis. Constantly moving, continuous passive motion is important. And there's sometimes not much we can do, because as we age, our bone mass decreases, they weaken, and people become more at risk for fractures. Movement is important, everybody. So even with your grandparents, if you can just say, hey, can you go walk around the kitchen table and come back instead of sitting in a chair the whole day, that's huge for them. Basically, when you move more, if we think of our living bones, we form more bone, and we recycle bone. So those are osteoblasts and osteoclasts. We didn't have a lot of time to talk about that this year, but that's basically why you want to keep moving. And again, what affects our bone forming, our age, physical stress, hormone levels. So this affects females greatly, males too, but females go through a lot of hormonal changes. Calcium and phosphorus to uptake. Remember, phosphorus was those things, phosphorus, calcium, important for our bones. And then genetic and environmental factors play a role in bone formation. Our skeletal systems interacts with other systems. So bones are attached, or muscles attached to bones, right? Or bones attaching with muscles. And our bone development is controlled by hormones, our endocrine system. The digestive and the urinary system provide us with calcium and phosphate for growth. And also the skeleton is like a reserve for those minerals. So this is just the last picture. Your integumentary system, which we know is our skin, basically. It removes heat, synthesizes vitamin D for calcium and phosphate absorption, and protects underlying bones and joints. Your skeletal system, you know, the functions here that we just went over, this is just showing you how all the systems work together. All right, and that is it.